My name is Laura Hanisch, and I work in the patient information team at NCCN. And I just have a few slides to go over before the presentation starts. So what is NCCN? NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 32 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for the NCCN patient resources. So what patient resources do we have? One of our main resources is the NCCN guidelines for patients. It is based on the clinical practice guidelines that is targeted towards clinicians. So for MPN, the clinical practice guidelines were updated to version 2022 in February. And just yesterday, we posted the 2022 patient version of these guidelines on our website. So if you go to nccn.org/patient guidelines and find MPN, you will find the latest up-to-date patient guidelines on MPN. Then related to the guidelines, we have the patient webinars such as today that complement the guidelines for patients. So at this point, I'm really enthused to introduce our presenters today. We're very fortunate to have such experts with us. Our first presenter is Gabriella Hobbs. She's the clinical director at the Leukemia Service at Massachusetts General Hospital Cancer Center. She's also assistant professor in medicine at Harvard Medical School. She's also on the panel of the NCCN panel of MPN. After Dr. Hobbs, we will hear from Meg Garvey. She is a nurse in leukemia practice at the Massachusetts General Hospital Cancer Center. And then our third presenter will be Stephanie Cindric. She is a patient advocate and someone who has been living with MPN. She has essential thrombocythemia. She's also a board member of the MPN Research Foundation. So at this point, I will hand over the presentation to Dr. Hobbs.
Good morning, everybody. I'm really excited to be here presenting with all of you, and also very excited to get to present with Meg Garvey, who is somebody that I work very closely with in clinic. So I can't wait for you to hear her as well. And then, of course, Stephanie. Okay, so we will start out with a little bit of an introduction to what the myeloproliferative neoplasms, or MPNs, are. So I'll start out with a disease overview and diagnosis. So what are MPNs? All the blood in our body is made inside of the bone marrow, and it is in the bone marrow that these diseases originate. So there are three main types of MPNs: essential thrombocythemia, where you have too many platelets; polycythemia vera, where you have too many red cells. But truthfully, in polycythemia vera, you can also have a little bit of an elevation in the white blood cell count and even an elevation in the platelet count. So it's not uncommon to have PV patients that have a little bit of an elevation in all of them. And that doesn't mean that you have two diseases. It's just one disease. Over time, these diseases can lead to scarring of the bone marrow, or sometimes patients can just present with scarring in the bone marrow, and that disease is termed myelofibrosis, as fibrosis is the medical word for scarring. And as you can imagine, if you have scarring in the bone marrow, it's difficult to make normal amounts of blood. And so in myelofibrosis, as opposed to having a lot of everything, you end up having, in some situations, not a lot of blood. So in order to make the diagnosis of these diseases, we have to follow what's called the World Health Organization criteria, and I'll spend a little bit of time talking about that. And so there's certain standard criteria that need to be followed in order to say that a person has or doesn't have an MPN, because there are other medical conditions that can lead to high blood counts, and so therefore having high blood counts doesn't equal having an MPN. Genetic testing is something that's really important for our diagnosis, and in some instances as well, a bone marrow biopsy. So myeloproliferative neoplasms share some things in common, and that's why they're kind of lumped together under this name. So first, like I said before, the bone marrow is making too much of something. And in myelofibrosis, you could say it's making too much scarring. The bone marrow biopsy also has characteristics of an MPN. So for example, when the pathologist looks at the bone marrow under the microscope, they'll see that there are a lot of cells, and that term is called hypercellular. The other thing that's important is that there are no other reasons for having high blood counts. And lastly, that there's something called clonal hematopoiesis. And basically that means in the stem cells, or the cells that give rise to the rest of the cells, there's a mistake that occurs inside that cell called a genetic mutation. And all of the cells that come out of that initial stem cell, their mother cell, will look the same. And that's termed a clone. And hematopoiesis is the term for making blood. So periodically, the World Health Organization comes up with new guidelines on what is necessary to meet criteria for a diagnosis. And in some cases, it seems obvious that, if you have high blood counts, you're going to have an MPN, but in some cases, it's not that straightforward. And so having a strict set of criteria to meet is actually really important to make sure that the diagnosis being given is actually the correct one. So like I said, having high blood counts is not sufficient to make a diagnosis of MPN. And so, for example, patients that have high red blood cell numbers can have other issues, like, for example, lung or heart problems. In rare situations, they can be tumors that make a hormone called EPO. And of course, in some circumstances, there can be patients that live at high altitude, and all of those situations can also lead to high red blood cell counts, but that doesn't mean that those patients have an MPN. High platelets can be seen in settings like iron deficiency or as a reaction to infection or inflammation. And then fibrosis or scarring can sometimes occur as a reaction to infection or medication. And so in all those instances, the blood counts may look like an MPN, but it doesn't necessarily mean that that person has one. So an important part of making the diagnosis of an MPN is to do what's called a bone marrow biopsy. So bone marrow biopsy is a procedure that can be done in clinic where the patient lays on their belly or their side and the pelvic bone is numbed. And then a needle is inserted into the pelvic bone to get a sample of the bone itself. That's what's called the core biopsy. And we look at that under the microscope to see kind of what the architecture of the bone marrow is. And then we also get the liquid part of the marrow that sort of looks like blood. And from that, we get a lot of information. Most importantly for our purposes is genetic information, which we do with special tests called next generation sequencing. And then cytogenetics, which is basically a picture of all of the genetic information or the chromosomes, and that's called the karyotype. And that really helps us to have objective evidence that there is or there isn't an MPN. And I'll hand it over to Meg.
So, good morning. Living with a chronic illness has been difficult, when you're newly diagnosed. And so as nurses, we try to sort of guide you with all the information that we've learned from the physician and being here for so long, wondering what your future is going to hold. Will I be able to have children? Can I still work? Fatigue. How do I deal with fatigue? Listening to your body, taking rests, trying to maximize your situation to the best with nutrition, exercise, living with treatment side effects, nausea, enlarged spleen, headache or itching. Those are all valid concerns. And as a nurse, we just try to answer those questions and say, yes, you can have quality of life, go on and work and just, enjoy life, actually. But I will say we have here that it takes a village. And so we do have a lot of resources available here at Mass General. And I encourage you to reach out and make sure that your places have the same. Once your diagnosis is made, you're nervous. How am I going to survive? I've got a family. I've got a life. I've got a job. So we have people that can help with that. There's social worker who can guide you through living with it. Financially, they can help you. Then there's also care managers who reach out and try to provide how are you going to afford these medications. And there's so many different groups out there that help with financial support as far as giving medications. nutritionists who help with, again, maximizing your care to have good nutrition, keeping your weight down, exercising. It's not just one person. We really do all work together. This is all manageable once you get over that initial shock of being diagnosed. In the beginning, you're going to have more frequent visits with your oncologist because of the fact that we need to observe your blood counts, observe your reaction to, is your body responding to the medication that your physician has started you on. If that one's not working, there's more behind it. And are you having side effects, and how do you work with those side effects? Whether it be nausea, smaller, more frequent meals, or being fatigued, and just listening to your body and working with it. It is a mind-body thing, and I think that we downplay that. I recommend that you listen to your body. When you come in for all these initial visits, it can be weekly, it can be bi-weekly. We'll do blood work, and you always discuss that blood work either with your physician or a nurse practitioner. We encourage you to ask questions, to write down the questions in between, because so many times you forget you wanted to ask. Then, depending upon your medications, whether it's aspirin or for ET and polycythemia vera, hydrea, which is very common. Most people are totally fine on that. Jakafi, which is most people have been totally fine. Enlarged spleen, and that might be one of them that you feel, and just learning about that side effect of the enlarged spleen, eating smaller meals, more nutrient-rich meals so that you have the energy. Then the pegasparinogenase and the Becemry, those are new, how to give subcutaneous injections. Much to their patients' dismay, I actually make them do the injection themselves once I've made them practice on a dummy. And they're always surprised at how easy that is, because nobody likes to get a shot, but it's a very small needle. Then you have therapeutic phlebotomy, where you go and you get your cells removed so that your red cells go down. Then with myelofibrosis, you've got different pills, again, subcutaneous injections. You might need blood transfusions, and that's all part of your visit. And I would recommend that you never know from one visit to the next sort of how long you're going to be there. There's many patients that come in for their blood work and see the nurse, and then all of a sudden, because of their side effects and their low counts, they may need a blood transfusion, and that may not have been on your book. You have to be willing to sort of go with the flow and just be prepared for anything. But not all of them. And once, your treatment is under control, you find that you're coming monthly. And then all of a sudden it's every 3 months. And that's so exciting. We love to see that. And it's rewarding to see. I mean, now we have people out that are, coming every 6 months, and that is just so exciting. And they have quality of life. They're living, they're working, and it's, I don't know, I love it. And so when you are here, we do want you to, let us know everything that's going on, that even if you think it's not related, we're here to help. And don't be afraid to reach out and ask your questions. Gabby?
That was awesome, Meg. Thank you so much.
Yeah.
And I think Meg really highlighted how important it is to have a team approach. And so I'm so glad that Meg's part of my team. All right, so I'll talk a little bit about PV and ET, and then I'll talk about myelofibrosis a little bit later because the treatment approaches for PV and ET are more similar. So we've discussed a little bit, the initial diagnosis and how to make that diagnosis, but just because somebody has a diagnosis doesn't mean that they necessarily need active treatment. That doesn't mean that they don't need visits or management or have questions, et cetera, but not everybody needs to be on medication. So first, it's important to understand why treatment may be given to somebody. And so one really important part of managing patients with myeloproliferative neoplasms is to control symptoms. And another important part of management is to prevent bleeding and blood clots. So there may be some patients that don't have any symptoms, but they're considered to be high risk for having a blood clot. And so those patients may need to be on medications. And then there may be some other patients that maybe aren't considered high risk, but have a variety of different symptoms. And so we may start treatments to control the symptoms. It's important to keep in mind that abnormal blood counts doesn't mean that somebody needs treatment. And the other thing that is important to keep in mind, and I hope this changes one day and then I can give this talk and say something different, but as far as we know, the treatments that we have right now don't cure the diseases or make them go away, but they do manage them. And the goal, like Meg was saying before, is to really help patients, whether or not they're on treatments, to live a full life with their MPN. And so let me talk a little bit about polycythemia vera. So in PV, we divide people up kind of rudimentary into what's considered low risk for having blood clots or high risk for having blood clots. So if a person is younger than 60, or if they haven't had a blood clot, and really has to be, and if they haven't had a blood clot, then those patients are considered low risk. And the standard of care currently is to give a baby aspirin, 81 milligrams daily, and then do what's called therapeutic phlebotomy, where a unit of blood is removed. Initially, that has to happen more frequently, and then over time, the goal is to need phlebotomy less frequently. It is also possible that some patients that are on a phlebotomy schedule only may need to ultimately go on medications because phlebotomy doesn't always work to control blood count. So that's something that's important to keep in mind. Now, if a patient is considered high risk, and high risk is either age over 60 or they've had a blood clot in the past, then those patients need to, in addition to aspirin and phlebotomy, we also have to give medications to lower blood counts. And we refer to that as what's called cytoreduction because we're lowering the number of cells. And the goal of that medication is really to normalize blood counts and hopefully to eliminate the need for phlebotomy. First line cytoreduction is with hydroxyurea or interferon. And we have several different interferons that can be used. There's pegylated interferon, and then there's recently a new interferon that was approved called ropeg interferon. And those are all fine to use in first line. And the NCCN, as well as other guideline agencies, really don't recommend one versus the other. Now, if a patient didn't do well with hydroxyurea, and they're on really high doses of hydroxyurea and their blood counts aren't controlled or their symptoms aren't controlled, then ruxolitinib or Jakafi can be given. And that's really just for PV patients. And for PV patients, whether or not they need to be on aspirin, phlebotomy, cytoreduction, et cetera, if patients with PV have lots of symptoms, then that also factors into our decision-making for choosing medications and for adjusting the doses of the medications. For essential thrombocythemia, it's similar, but it's a little bit different. So in essential thrombocythemia, we use age as well, similarly to PV, a blood clot history, but we also take into account the mutations. And so up until now, I've hinted at the mutations, but haven't spoken too much about that. So the vast majority, over 95% of patients with polycythemia vera will have a mutation in a gene called JAK2. In essential thrombocythemia, or ET, it's a little bit different. So about half, or 50 to 60% of patients will have a JAK2 mutation, and then a third of the patients will have a mutation in another gene called calreticulin. And so patients that are calreticulin mutated are usually considered lower risk for blood clots than patients that are JAK2 mutant. And so we take those factors into account, age, history of blood clots in the past, and mutation, and we divide patients up into very low and low risk, intermediate risk, and high risk. And so patients that are very low risk, actually don't need any treatment. They don't even need aspirin because studies have shown that the aspirin doesn't actually help that much. It actually increases the risk of patients having bleeding. Patients that are in that intermediate category, either having a JAK2 mutation, or if they're over the age of 60 without a JAK2 mutation and no blood clot history, usually are put on aspirin, but cytoreduction or medications to normalize blood counts doesn't always have to be given. So that's really where we have a discussion, patient and care team, to see what's right for each individual patient. And for example, to put it into a little bit of perspective, if I have a patient that's in the intermediate risk category, but let's say that that person has a lot of cardiovascular risk factors, like they've had a heart attack in the past, or they have hypertension or diabetes or other things like that, then that may sway me more to consider starting medications to lower blood counts. But let's say that another patient is incredibly fit, has no medical issues, etc. Maybe we wouldn't consider giving that person medication to lower their blood counts. So the intermediate risk group is a little bit of a grayer box. And then patients that are high risk, similarly to those patients with polycythemia vera, should really start on medications to lower their blood counts. And for ET, we're a little bit more limited in terms of treatments, and we have hydroxyurea and pegylated interferon. Ropeg interferon is being investigated in ET, but it's not yet approved. And ruxolitinib or Jakafi has been studied in ET, but it's not specifically approved for this indication. So, okay, let's say that a patient falls into the not needing treatment. Well, what does that actually look like and feel like in real life? So initially, it's important to follow with an MPN doctor or with a team of a care team that is familiar with the MPNs and can follow your blood counts regularly. At each visit, what you can expect is to go over not just the blood work, because as we just learned in the previous slide, the blood work doesn't tell us the whole story, but also to talk about what are the symptoms that are going on. Perhaps at your last visit a few months ago, there was nothing going on, and then you've noticed that you get this itching after the shower, or there's other things. So it's definitely important to talk about MPN-related symptoms, and I'll talk about that in a second as well. And then based on symptoms, based on blood counts, based on perhaps other medical issues that are going on, etc., then we may discuss whether treatment needs to be started or not. And one of the things that I do a lot, and Meg can attest to this, is really discuss how to proactively manage your health in order to keep you as healthy as possible, because lifestyle modification, I think, has a really important role in the management of a patient with MPN, and especially in patients that are undergoing, what's called watchful waiting, because I think there is some degree of anxiety of, saying, wait, what do you mean? I went through all this testing. You talked to me about these mutations. I had a bone marrow biopsy, and now we're just going to wait. And so I think that can be difficult sometimes, and I think it's important to keep in mind that diseases like ET and PV, you can think about them in a way as another cardiovascular condition. What do I mean by cardiovascular conditions? So like high blood pressure, diabetes, high cholesterol, obesity, smoking, etc. Those are things that can affect your cardiovascular system, like your heart, your arteries, your veins, etc. And similarly, in ET and PV, managing a healthy lifestyle is important to prevent any cardiovascular complications. And so having a healthy, active lifestyle is important to preventing those complications. And in addition, I find that really having a healthy lifestyle gives some control back to the patient and helps to feel like you're more in control by preventing these complications, but also really helps to manage some of the symptoms. So some patients really feel much better in terms of their energy levels, for example, when they have, a regular exercise routine. So that's definitely something that I spend a lot of time talking about in clinic. So along those lines, there are some kind of general considerations of managing MPN patients, whether or not they need to be on medication specifically for the MPN or not. So managing cardiovascular comorbidities is really important. And one thing that I feel like happens a lot when a patient gets diagnosed with an MPN is that all of a sudden their MPN team becomes kind of their primary care team. And although that's great, we love obviously seeing you and getting to know you, et cetera, we are not the primary care doctors. And it's really important to have an actual primary care physician that can help managing the cardiovascular comorbidities, making sure that your blood pressure is fine, that your cholesterol is okay, and checking for diabetes and other things like that. as well as discussing perhaps smoking cessation if that's relevant to you. And then doing what's called healthcare screening. So making sure that women are up to date with mammograms and pap smears, and everybody is up to date with their colonoscopies and those kinds of things, because like I said before, the goal of living with an MPN is to live well. And so managing the rest of your medical conditions or preventing other medical conditions is really important. And then I discussed this previously, but symptom assessment is also really important. So here's a snapshot of the MPN Symptom Assessment questionnaire. And so this is actually a pretty easy questionnaire. You can just find it online. It's a 10-point questionnaire that I do with my patients frequently when they come to see me. And basically, it's just 10 easy questions to answer, where 0 is perfect and 10 is the worst symptoms imaginable. And it's something that, you know, if your care team isn't doing, you can really look this up online and fill it out for yourself and even bring it to the visit. And it makes you more prepared to ask the right questions in your visit. And so, you know, if night sweats have become a problem, or fevers or bone pain or itching or other things have become a problem, it's great to know this in advance and be able to bring it up at your doctor's visit. And then it's also great to be able to keep track of how these symptoms may change over time. So let's talk about a question that I get often. What is the outlook? What can somebody expect with having a diagnosis of ET or PV? So for the most part, the general outlook is pretty favorable. Patients will live with these conditions for decades. And that's why truly living with these conditions is so important. I don't like to dwell on this, but it's important to just hear it and then kind of put it away and to not try to think about it all the time. But patients with ET have a risk of transformation to what's called acute leukemia, and that's fortunately very rare. It happens between 2 and 4% of the time. There's a risk of transformation to myelofibrosis, which is somewhere between 5 and 10% or 4 and 9%. But really the main thing to worry about with ET is the risk of having blood clots or thrombosis. In PV, the numbers are a little bit similar, but maybe some of the complications are more frequent. And so the risk of leukemia may be around 5%. The risk of myelofibrosis transformation is about 5 to 10%, and some studies maybe show some higher rates of myelofibrosis transformation. And then the risk of having blood clots is about 27%. And so when you look at these numbers, really the most common complication in PV and ET is those of blood clots, which is why managing that is so important. Up to you, Meg.
So MPN, which Gabby has said is caused by mutations, can lead to inflammation, which then can lead to having the blood clots and being on aspirin or blood thinner, a different type, and then managing with that. And whether it be flying, whether it be exercising, whether it be coming in for your bone marrow biopsy, we would guide you on what to do, because you can live with this. You can live well with this. And it's important to know that. But again, we do want to hear your symptoms, whether it be fatigue, whether it be early satiety, whether it be shortness of breath, potentially being a clot, or pain in your leg, potentially being a clot. Don't ever hesitate to call, because if you don't call, something's going to be really wrong. And it's just easier to get it dealt with. And we're here, you know, we always will let you come in and be seen. We try to, as nurses, we try to, you know, work with you on taking your medications, whether it be charting and remind you, you know, because some of them are twice a day, and that's a lot for people, but it helps with your symptoms. It helps improve your counts. We've given pill boxes to people. We've given calendars. I always remind patients to bring a list of their medications, if actually not even their medications with them, because a lot of times they get confused. And so if they bring everything that they're taking, then they can go through it with you and confirm, yes, this is what I'm taking. We're just trying to make it easier for you, for sure. We're here to listen, if it's something that we as nurses can help with, we do. If not, we involve social work. We also have a program here for because if things do progress and, all of a sudden you have to tell your children that you have something, we have a PACT program, which is parenting at a challenging time. And so that helps parents guide sort of age appropriate information for their kids. There's many opportunities to help you live with this. We also encourage you to work on things that are in your control, because it does feel like things are out of your control at the moment, especially if you're in the watchful waiting. So we encourage healthy diet, more nutrient-rich foods, smaller, more frequent meals. We encourage exercise, because you feel so much better when you're outside and doing things. Remind you that you want to wear a hat, sunscreen, those kind of things. We also try to help you with getting good night's sleep, because rest is important. It's all part of it, and we're here for you to help you live the best life that you can given your diagnosis. I encourage you to find a team that you're comfortable with. I feel blessed because I feel like when our patients come to us, we are able to provide them the best quality of care. If you don't feel like you have that, I definitely would recommend getting a second opinion. We have a lot of people that come for second opinions. We have a lot of people that go for second opinions. Then also the NCCN guidelines are really valuable for you. Don't be afraid to ask for help. We're here. And again, come prepared with your questions and write them down, because you do forget them. It just makes it so much easier. I do recommend keeping a folder or a notebook with your treatment, your medications, your future appointments. It just makes it easier in case you need it. And then you also have it. Now it's Gabby.
Thanks, Meg. Okay, so now I'm going to change gears a little bit and talk about myelofibrosis. So we mentioned this a little bit at the beginning. So there are kind of formal criteria that need to be followed in order to make the diagnosis of myelofibrosis according to the WHO, or World Health Organization. So there are 3 major criteria and 1 minor criteria. So basically, in ET and PV, although we recommend doing a bone marrow biopsy, oftentimes it's not necessary or not done, even though, strictly speaking by criteria, it should be done. I'm happy to answer questions about that later. But in myelofibrosis, I really do think a bone marrow biopsy is important. And so the biopsy must look like myelofibrosis. Basically, when we look at the bone marrow biopsy under the microscope, there is evidence of scarring. The bone marrow can't look like anything else. Sounds kind of obvious, right? And then really there has to be the presence of a mutation. So either the JAK2 mutation that we've discussed, about half of the patients with MF will have a JAK2 mutation. About a third will have a mutation in this gene called calreticulin, or CalR. A small percentage, around 5 to 7%, will have a mutation called MPL. And then there's a smaller percentage of patients that maybe don't have any of those mutations, but generally even those patients, although not always, may have other mutations that are less commonly found. And then the minor criteria includes abnormalities in blood counts, such as anemia, having a slightly increased white blood cell count, having an enlarged spleen, having a high LDH, that's something called lactate dehydrogenase, which is just a marker of cells kind of growing rapidly, and then having something called leukoerythroblastosis. So when we look at the blood counts, we can see that there are young cells floating around in the blood that maybe wouldn't belong in the blood, and that's termed leukoerythroblastosis. So here's kind of the general approach to myelofibrosis. So patients can be divided based on the risk of their disease. And the risk in myelofibrosis is a little bit different than the risk scores used for essential thrombocythemia and polycythemia vera. But in order to come up with, is a patient low risk or high risk, et cetera, we have different calculators that can be found online. One is called the MIPS and the other is called the DIPS. So lots of IPS. And so basically patients that are in the low risk group or very low risk group are essentially patients that have mostly normal blood counts and don't have symptoms. And so for those patients, watchful waiting or observation can also be used, similarly to PV and ET. Patients that fall under the intermediate risk category may also be observed unless they have issues with symptoms, and that's what's called constitutional symptoms, things like fevers, night sweats, itching, weight loss, etc., or they're bothered by their spleen. And so for those patients, we have actually now 3 JAK inhibitors that are approved. The first one is ruxolitinib that was approved in 2011. Then a few years ago came fedratinib. And lastly, about a month ago was the third one called pacritinib. And this is for patients usually with low platelets. And so the JAK inhibitors really are wonderful medications to improve symptoms and to reduce the size of the spleen. Now, if patients have low blood counts, there are a variety of different medications that can be given. One of the things is growth factors. The most commonly is a medicine type called EPO or erythropoietin. And that's a hormone normally made by the body, but we basically give higher doses of that to kind of stimulate the bone marrow to make more red blood cells. Then we can make medications that are similar to testosterone, which can sometimes help to bring the red blood cell counts up. And then less frequently, but occasionally used, are the medications called IMiDs, thalidomide or lenalidomide, which are pills, and those can be given with or without steroids. Now, patients that are in the higher risk groups really should be evaluated for transplant candidacy. And in fact, some intermediate risk patients can be considered for transplant as well. So bone marrow transplant is really the only curative treatment that we have available for patients with myelofibrosis. And although this is obviously a very daunting thing to consider, it's really important to know that over the last decade, the outcomes of patients with myelofibrosis that receive transplants has improved significantly. And so I would say that even contemplating a bone marrow transplant may be terrifying, don't be afraid to go to that first visit with a transplant doctor or to ask for a referral to a transplant doctor, because having information is never going to hurt you. It may be that you don't need a transplant. It may be that right now is not the right time, etc. But I think having that initial visit and discussing with a transplant team, what does it mean to get a bone marrow transplant, I think is really important. And lastly, patients in the intermediate or higher risk categories can also be considered for clinical trials if appropriate. And clinical trials are important in certain situations and something that's important to talk to your clinical team about as well. So let's talk a little bit about JAK inhibitors, since they're really the main medicine that we have to manage patients with myelofibrosis before they go to transplant. So the great thing about JAK inhibitors, and the one we have the most experience with is Jakafi or ruxolitinib, is that they really can lead to significant improvements in symptoms. There are some patients that really have debilitating fatigue and then debilitating itching. And once we start them on Jakafi or on the other JAK inhibitors, really that itching kind of can go away overnight. So it's important to know that there are medications that can really help symptoms. They can really lead to significant reductions in the size of the spleen that can really make patients feel better. It allows patients to eat more normally and regularly, to regain some of the weight that maybe was lost because the spleen was so bothersome. And then there's some studies that show that that the JAK inhibitors can lead, or ruxolitinib in particular, can lead to a survival benefit. That survival benefit, meaning people live longer, I think probably more has to do with the fact that patients had previously been maybe weakened, losing weight, not able to eat well. And then Jakafi really makes people feel so much better that I think that helps people live longer. I don't think that it has anything to do with actually changing the underlying disease and preventing it from getting worse, unfortunately. Hopefully one day we'll have a medicine that'll do that outside of transplant. And the other thing that I think is really important is that the JAK inhibitors really do improve quality of life. A downside of the JAK inhibitors is that they all can be associated with lowering the blood counts. And so this is particularly problematic in patients that may have symptoms from a spleen or symptoms from the myelofibrosis itself, and also low blood counts, because it may lower the blood counts further. These medications, like I sort of hinted before, don't alter the progression of disease. So if the myelofibrosis is a type of myelofibrosis that is going to progress, meaning the blood counts will go down over time, or there's a risk of transformation to leukemia, these medicines can't stop that from happening. We don't know exactly which patients will lose response or how quickly it'll happen, but generally patients will be on JAK inhibitors for a few years, and many times the patients will lose response, meaning maybe they were on one dose that was working really well, but over time maybe they need a higher dose, or they don't respond to even the highest doses. And then one of the things, you know, that the research community is really working on a lot is what happens after patients can't be on Jakafi anymore. Thankfully, there are a few different JAK inhibitors, and it looks like, you know, patients can respond to one JAK inhibitor if they haven't done well with Jakafi. But this is an area that really requires more research. So this I wanted to just show to end on a positive note after what I just said. And I want you to know that there's a lot of research going on right now in the world of MPNs and for myelofibrosis in particular. Rux, I use to abbreviate ruxolitinib or Jakafi, but just take a look and see there are lots and lots of different clinical trials that are trying to improve outcomes and help patients with myelofibrosis live better and longer. So there's lots of medications that are undergoing phase 3 testing, meaning this is the last trial that they need to do in order to get approval by the FDA. So lots of the trials are using, you know, ruxolitinib or Jakafi in combination with new drugs. And then there's other JAK inhibitors that are also being studied for approval. And then imetelstat is none of the above. It's kind of like a different form of chemotherapy that is also being studied for myelofibrosis. So really, there's lots of hope because there's a lot of people that are really interested in studying myeloproliferative neoplasms and improving outcomes. And I'll hand it over to you, Stephanie.
Yeah, thank you. Thank you. Hi, everybody. I'm Stephanie Sindrick. I was diagnosed with ET as a teenager almost 25 years ago. I want to talk about when to see an expert, because I'm a big believer in including an MPN specialist in our care. So makes sense, certainly at a time of initial diagnosis. You want confirmation that you've been properly diagnosed, make sure that that you do fit the criteria. Sometimes it's also helpful if you've been diagnosed, you want to get a second opinion regarding confirmation of the diagnosis, as well as treatment or watchful waiting, whatever's been recommended. Make sure that an MPN specialist is in agreement with that plan. Another time where it may make sense is if there's a big change in symptoms, a big change in your lab results. If there's kind of been a curve in the road, that would also be a good time for confirmation that you're on the right path. And so an MPN specialist can be the one to identify that. To follow up on Dr. Hobbs, you know, she showed that list with, there's a ton of research, there's a lot of treatment options in the pipeline. So if you have any interest in participating in a clinical trial, that would be another great way to shake hands with an MPN specialist. When you're sitting down or when you're meeting with a local hematologist, it's a fair question to ask what their experience is with treating MPNs in general or your diagnosis specifically. If you know, they are honest and say, I have a handful of patients, that may make you wonder that you want to make sure that you are in the hands of somebody who's up to date on all of the new knowledge, because with all the research that's happening, you know, you want to make sure that you're in the best of hands. And then also for maintenance, that's the category I fall into. So I see an MPN specialist. I travel twice a year at least to meet with an MPN specialist. And then I'm followed here locally with a hematologist a little more often. Okay, so resources. So information. When I was initially diagnosed, this was back in the late 90s, so getting good information was a little difficult. I think reaching out to some big institutions, this is not a comprehensive list by any means, but National Comprehensive Cancer Network, National Organization for Rare Disorders, Leukemia and Lymphoma Society, ASH, the American Society of Hematology. These are really great institutions that are research-driven, education, patient advocacy. You also want to, focus in on MPN focused groups. So MPN Research Foundation, driving force and funding really great research, as well as providing patient advocacy. And then there's some other groups like MPN Advocacy and Education International, MPN Education Foundation, Patient Power, MPN Cancer Connection. These are all great groups that are focused on education and providing up-to-date information. Social media outlets are great. It's a great way to connect with other patients and share experiences, but I would make sure you're tuning into either these big institutions or MPN focus groups to get accurate information. That's super important. All right, so financial assistance. Some of these medications can be costly. The traveling to see an MPN specialist can also add up. So there's a few different categories here. There's patient assistance programs. These are also sometimes sponsored by, pharmaceutical manufacturers. There's a group called RX Assist, or you can just go directly to the manufacturer of the medication that you've been prescribed. They will often have patient assistance programs. So these are great. These are very helpful in scenarios if you're not insured or if you're, what we call underinsured. I have used these types of programs for some of my medications when I had coverage, but I didn't have specialty medication coverage. And so this type of program allowed me to start on the medication that was recommended without any out-of-pocket costs. The next group would be a copay assistance program. And a couple of examples are foundations like Good Days or the PAN Foundation. Both are really great. So in order to qualify for these types of programs, you do have to have coverage for the medication that has been prescribed to you. It's really a scenario if the medication is cost prohibitive, you have a high deductible, or just the copays itself are unattainable. I am currently using one of these programs to help cover it. I'm on a medication called Pegasus, which is an interferon, and that's been very helpful in allowing me to continue on my medications. You do have to financially qualify. It's an annual grant, essentially, so you're allotted a certain amount. And so I would encourage you to look into either of those programs if you've been recommended one of these specialty medicines. And then travel assistance programs. Some of these same foundations will also have grants for travel assistance that are given like on a one-time basis or as an annual grant that can be renewable. And that can be really helpful. We keep highlighting the recommendation to sit down with an MPN specialist. And if that's been cost prohibitive, sometimes that can mean all the difference is getting that travel assistance. So look into that as well. All right, be your own advocate. So education, information, knowledge is power. You really have to learn everything you can about your diagnosis and make sure that you are circling back and keeping up to date with new information as it is coming out. Connection is great. Finding support groups online. There's programs that will offer one-on-one support where you can be a mentor to other patients or be mentored if you're newly diagnosed. Emmerman Angels program is great. They will help connect you with someone who's a veteran living with your diagnosis, and they can really help guide you in how to manage in all aspects of the disease. So connection is really important. And communication. Communication, not only, with your healthcare team, but also with your support system. Megan was saying earlier that it takes a village, and I will co-sign on that. So communicate, be honest, so that your village can help you, whether it's your healthcare team or who you live with at home or in your circle. So with your healthcare team, being focused on what your short-term goals, what your long-term goals are, share that with them, to have that discussion, whether it's at your initial consultation or at a follow-up visit. Sometimes they change. So, examples would be family planning if you're looking to, start a family, or if, your counts are kind of questionable, but you really aren't ready to start, treatment, you want to continue watchful waiting. How can we do that in a safe way? Make a list of your questions and concerns, write them down, because you will forget. I've lived that many times over. Bring that list with you. They're happy to see that list, I can assure you, because it does kind of help to use everybody's time wisely. The other thing is listening, and whether you bring a second pair of ears, listen carefully to what the recommendations are, take notes. If I don't have someone with me during my visits, I'll try to, make a list of what was discussed and what was recommended, just so that as I'm, reviewing it later, it's still pretty clear as to what direction we're going. And then what applies to your healthcare team, but also your support system, is honesty. Be honest with what you're going through. A lot of what we experience as MPN patients, it's invisible. It won't be seen unless we speak it. And so help your healthcare team by being clear about symptoms you're having, whether they're new or this hasn't happened in a while. This is getting worse. If you're having a difficult time with side effects from the treatments, how do we balance that better? They want to help you live well with these diseases. And then the other part is, communicating, being honest with your support system, whether that's, friends or family. Again, they're not going to know, and they're not going to know or see it. And so if you're having a bad day with side effects, the fatigue, it's okay to set those boundaries for yourself and communicate those needs to your support system. And then what's not listed here, but another key word I would say is balance. And it echoes a lot of what was brought up by Dr. Hobbs and Megan. It's controlling what we're able to, because a lot of this feels like we don't have control, or we don't have control over some big things in our lives. So what can we focus on? And so that's living a healthy lifestyle. It's living in your best way in every other way possible. It's taking care of yourself physically and emotionally, making sure you get enough rest. I'm not always the best at doing that. And then I get the reminder and you say, okay, I got to set this boundary back a little bit. Managing your other medical issues, high blood pressure, things like that, making sure you're keeping tight control on what you can, like I said, and then just staying up to date with all of your other health screenings. So, okay, so we'll move over to the question and answer component. We had our initial question that came in. It says, this is from Barbara. It says, I've been on Jakafi 10 milligrams times 3 years, and I've had 3 phlebotomies in that time. The last 2 phlebotomies were done 6 weeks apart, and due to fatigue, I was found to be anemic. Shouldn't iron levels be a part of testing along with CBC, since Jakafi and phlebotomies can cause anemia? Dr. Hobbs, I'll put that in your direction.
Sure. So overall, sounds like doing okay with not that many phlebotomies. I think that may require a little bit more of a question with your care team that have a fuller picture of what's going on. But it's important to know that, there's many different things that cause anemia. One of them is iron deficient, and patients with PV that have had a lot of phlebotomy by definition are going to be iron deficient because we've taken out that iron. And so checking iron is fine, but it may not be the answer for everybody. And we also need to balance that giving iron may also kind of worsen the red blood cell counts. And so I would just say, kind of as a general thing, if a patient is having too much phlebotomy, that's also not a good thing because you'll become anemic. But it's important to kind of talk about, is this the right dose of Jakafi if it's maybe lowering your blood count? So it's something to talk to your care team about for sure.
And I've gotten a few questions regarding Ro-Peg interferon. And so it says, since the FDA approved Ro-Peg interferon, is it used in treatment-naive patients with PV? Would it be considered a first-line therapy?
Sure. Yeah, there's a lot of interest, I think, in the MPN community about Ro-Peg interferon because it's been studied undergoing clinical trials for such a long time. And so, yes, it can definitely be considered in first line, and it's approved that way. And it can also be used in second line, meaning somebody that was on either pegylated interferon like Pegasus or on hydroxyurea or on Jakafi can switch over to Ro-Peg interferon. So it really depends on why a person needs to be on a medicine to lower their blood counts. I think there was one question too, Stephanie. I'm just going to answer that one as well since I'm on the subject. One of the Ro-Peg interferon studies specifically looked at younger patients and those patients that would otherwise be considered low risk and started them on Ro-Peg interferon. And that's an answer that I wish I had a better answer for that one. I think that's really like a one-on-one kind of discussion. And the reason why I say that is that just because patients that are low risk do quote unquote well with Ro-Peg interferon, meaning their blood counts are controlled, or even if their level of the JAK2 mutation goes down, we actually don't have any studies that say that starting early will lead to changes overall in how long a person lives, or if those patients will have a lower likelihood of then having issues with PV turning into myelofibrosis. And so I think there's a lot of excitement with the interferons and thinking that, over time, the level of the mutations goes down. So that has to be good. But we, like I said, we don't yet know what that really means for a patient's life. And so although I don't think it's necessarily wrong to start somebody that's low risk on Ro-Peg interferon, it's not for everybody. We need to remember that these are still medications that you're putting in your body that otherwise wouldn't be in your body. They have a lot of cost associated with them, thankfully for the most part, depending on where you live and your insurance and whatever. And the company itself has been, very helpful at trying to get that prescription for our patients without having to break the bank. But, in some cases, some patients may have to pay some money for the medication, even if it's, quote unquote, just a copay. And there's also the possibility of having side effects from the medication. So although Ro-Peg interferon is a relatively well-tolerated interferon, it still has the potential of having side effects. And so I would really think very carefully about starting a medication in a patient that's young that otherwise doesn't have a reason for lowering their blood counts.
That's great. Okay, so here's a question. Let me go back to it. It's a question regarding your hydration status and hematocrit percentage. Is there a risk of overhydration having a result on your CBC? If you're overhydrated, will that show a lower percentage of your hematocrit percentage? So I guess if you're looking at considering phlebotomies, or does that
I would
come
say
into
that's
the
possible,
equation?
but I would probably not spend too much time obsessing about being too hydrated or underhydrated before your visits. I think truly overhydrating in a way that would really, really lower your blood counts would be really difficult to do. It is true that those numbers can vary a little bit. If you're like dehydrated, the hematocrit may look higher than it otherwise would be. But I would just say for most visits, just do your usual thing before the visit. I wouldn't try to either over or underhydrate too much. And it won't affect the white blood cell count or the platelet either. So that can also
Yeah,
give us a hint.
yeah. Okay. Prognosis. Is there more specific testing for prognosis?
So
This is for a
each disease
PV
is a little
patient, by the way.
different.
Yeah.
And I would say, you know, in ET and PV, the like prognosis overall is excellent. You know, people live with these diseases for many decades, and really the main management is trying to prevent blood clot complications because that can affect, you know, how long a person lives well or lives in general. And so, I wouldn't try to get more accurate with that because, you know, we're looking at so far out that it probably isn't meaningful. To your day-to-day life. And also if you're well managed and you're taking your aspirin or doing your medications, that also changes the outlook. For myelofibrosis, it's a little bit different. And so there are different risk stratification scores. One is called the DIPSS plus or DIPS plus, and the other one is called the MIPS 70 or MIPSS. And, you know, that's something that I would encourage you to talk to your doctor about. You know, fill in those variables. It includes things like blood counts and mutations and those kinds of things. And it gives you a sense of like where you are in a general map. What I would say about prognosis in general is that you're not a number. And so just because you plug into a formula and it gives you a certain, you know, outlook, that's not a promise, all right? It's not like this is exactly how long you are going to live without issues or how long you're going to live, period. Nobody can do that. And I think that, you know, one of the themes that we talked a lot about is learning to truly live with the MPN. And I'm not saying that to underestimate how difficult it is to live with a condition where you know something bad can occur at some point, but really to focusing so much on how long am I going to live or live well or not have complications can also kind of detract from the more positive things like making sure you're going to the doctor, making sure you're taking your medications, making sure your blood counts and your symptoms are controlled, and all of those things. So it is important to think about that, but I wouldn't spend all of your time thinking about that.
I agree. Yeah, that's great. Okay, long-term question regarding any long-term risks of being on hydroxyurea. How do you counsel your patients with that?
Sure. So, hydroxyurea is a medicine that's been around for forever and ever and ever, definitely since before I was born. And so we know that hydroxyurea is a relatively safe medication. Patients can be on it for decades. We give it to children with sickle cell anemia. And so we think of hydroxyurea as generally a safe medication. Now, that being said, it is still a form of chemotherapy. And so it definitely has potential risks. So there's some that are common and that we talk about all the time. Meg hinted at this when talking about how to live with an MPN. So simple things when you're out in the sun, you know, make sure you have good skin protection because hydroxyurea can make you more sensitive to the sun. It can be associated with mouth sores at higher doses. It can rarely cause, you know, a sore on the legs in particular that doesn't heal. That's super important to be aware of because if it happens, you have to stop hydroxyurea, period. Some people, you know, obviously get allergic reactions to a medication. They may have rashes, although that's not super common. And then I think the thing that we worry the most is if I'm on hydroxyurea, does that increase my risk of developing leukemia? And the answer is we don't really know 100% for sure. But I would say the consensus in the field to some degree is for patients that are really very young, those that are maybe 20s or 30s, we don't love the idea of being on hydroxyurea for 4 decades. And so those patients are much more likely to get started on an interferon than on hydroxyurea. But the other thing to remember, and this is a question that I get a lot, is like, am I going to be on this forever? You know, forever is a really long time. And so you may be on it for now, but for all we know, in a few years, there may be a completely different medication. Or hydroxyurea may be the right medicine for you, even if you're 20 or 30 years old, because that makes sense with where you are in your life right now. But it doesn't mean that you're committing to it for the rest of your life. It means that you are committing to that medication today. And we can discuss and change depending on your situation over the next couple of months or years.
Excellent. Okay, so this is a question, does does the treatment in a young adult differ from an adult? So part of that you just answered with your answer to that. Anything else you want to add to younger adult versus an older adult?
Yeah, I love that question. So, one thing is using like these calculators, right? Where, you get plugged in, and if you're young, you're probably low risk, and if you're older, you're probably higher risk. And so generally speaking, the risk scores that we utilize to determine if somebody needs to be on treatment or doesn't need to be on treatment are different by age. So an adult that's older gets treated different than an adult that's younger. But I think that younger patients also have other considerations that older patients may not have. For my younger patients, we more often talk about, how do I go to work with my MPN? What are special considerations? What do I need to tell my office in terms of when I'm going to miss work? Should I talk to my boss about the fact that I have this or not? Maybe that person wants to get pregnant. So should we talk about what to do in terms of pregnancy and what medicines are safe and not safe during pregnancy? And so I would say, although a lot of the medications are similar, younger patients are less likely to need medications, but they definitely have other needs that may be, very unique to a younger population of patients that, is thinking of working, having children, parenting, et cetera, that may be less relevant for some older patients.
Good. I know we're getting close to our time. This question is regarding a triple negative ET. So what would be next steps in someone newly diagnosed with triple negative ET?
So I'm glad we have that question. Management for a person that has triple negative ET is the same as anybody else. And as far as we know, the prognosis for triple negative ET versus JAK2 mutated ET or calreticulin ET is not different. And so the first thing that I would make sure is that the diagnosis is actually that of ET, and that reactive causes or other reasons for giving you high platelets have been excluded. And so although not, even though the guidelines recommend that everybody has a bone marrow biopsy, but I recognize that some patients don't end up having a bone marrow biopsy with PV and ET. But I would say in the case of triple negative patients, it is important to have a bone marrow biopsy and make sure that the morphology or what the bone marrow cells look like actually does look consistent with ET, and that there aren't other diseases going on. So, just not that long ago, we've had a few patients that have really high platelets and they're triple negative, but then it turns out that they actually have another type of leukemia called chronic myeloid leukemia, or CML, that can present with really high platelets. So I think excluding other conditions is particularly important in the case of triple negative ET. But if, all of those things have already been done, then the management follows the same recommendations that I was discussing before. If you're a patient that is young, that doesn't have other risk factors, then perhaps, you need watchful waiting and nothing else, maybe a baby aspirin. But if you're over the age of 60 or have other cardiovascular risk factors, et cetera, then perhaps a medication like hydroxyurea or interferon should be considered for lowering your blood counts.
That's great.
Yeah, so we are out of time today. I did want to note, someone asked about the NCCN guidelines for patients. So in the chat, I put the link, but you could also go to nccn.org/patient guidelines, that's one word, and access the guidelines from that link. I want to thank our three presenters. It was very informative. There was a lot of information. And I would like to conclude with thanking our supporters. We wouldn't have this webinar without the NCCN Foundation. They provide funds, and they also obtain funds from different funding sources. So thank you, NCCN Foundation, and our corporate supporters. And on that note, everyone, have a nice day.